Right now, the latest evidence is that there's about between 8 and 10% of Mohs surgeons who are fellowship trained across the country who are actively practicing with the use of immunohistochemical staining for certain high-risk tumors, whether it be melanoma or a advanced stage squamous cell carcinoma, or even other more rare orphan diseases like extramammary Paget's disease. But this is starting to be more regularly implemented into our fellowship training. And fellowship training is something that I would really encourage all patients to seek out in their Mohs surgeon, because it is a rigorous process by which the surgeon is trained over a course of 1 to 2 years, where the minimum requirement in that time period is to have at least 600 Mohs surgeries completed before your level of proficiency can be adequately evaluated. And it's not just the surgical resection. I think a lot of people get caught up in the removal of the cancer and the actual reconstruction of the wound that we create in the process. And we'll talk about reconstructive surgery. But really the pivotal point that makes Mohs surgery different than traditional surgery is the ability for the surgeon to also act as the pathologist and to make sure that to their trained eye, they can see that there's no evidence of skin cancer left behind. So I would argue that is the most important part, because what's the point if we can't tell, even with the use of the microscope, that the cancer is completely inadequately removed, then we have a false sense of security that we're effectively treating.